When you see a contraction, again, that may mask funneling or unmask funneling, depending on the case. And again, you don't want to take this kind of measurements as shown here in the calipers, but you want to just take the functional cervical length. Sometimes there can be a local contractions. You can see here X-ray echogenicity in this part of the cervix. These slides are from Ed Guzman. And if you wait long enough, usually these contractions over time resolves. And sometimes, as you can see here, funneling can be masked. And the remaining cervical length here, this measurement of the closed cervix is less than 1 centimeter. So this lady is very high risk for preterm birth. Here's another example of a contraction up in the lower uterine segment, but the remaining cervix looks okay. And sometimes you see a contraction that makes the cervix very curved. Again, you have to wait, make sure the bladder is empty, and then remeasure the cervix later on. So the best measurement, again, to emphasize, is the cervical length, as it is the most reproducible and most predictive. Dynamic changes can occur and improve the predictive accuracy. Therefore, when you see those, record the best, shortest cervical length. Here is a study of over 700 high-risk women that we followed at Jefferson. As you can see, between about 14 weeks to about 28 weeks, the cervical length is about the same. In most studies, about 35 to 40 millimeters in average. Before 12 weeks, very hard to distinguish the lower uterine segment from the true cervical length, so we do not recommend doing cervical ultrasound for prediction of preterm birth before 14 weeks. And also after 20 weeks, the cervix begins to shorten anyway, and even in patients that deliver at term, and therefore cervical ultrasound is not recommended after 20 weeks for the prediction of preterm birth. As a screening test, again, cervical ultrasound is not a diagnosis test, but as a screening test, transvaginal ultrasound does really well because it studies an important conditions, as we've seen. It's a well-described techniques, which again we've reviewed. It's safe, acceptable, very reliable, and reproducible. Recognizes an early asymptomatic phase, as I've showed you, and it is accurate in its prediction. And now there is finally some treatments that can be effective in prevention, which I'll review in detail to put transvaginal ultrasound in its clinical application. Again, there's many papers that review the fact that it's a safe procedure, even in patients with premature preterm rupture membrane, with a randomized study by Dr. Carlin in '97, and it is acceptable by over 99% of women who would have it again in the future. It is reliable, and here I want to make a comparison to nuchal translucency. I think just like nuchal translucency and other ultrasound measurements, you have to make sure that you've done a number of practice transvaginal ultrasound cervix that was reviewed and checked for quality, and you have to make sure that you have a quality assurance program for your transvaginal ultrasound cervix. Once you do that, inter-observer and intra-observer variability are very acceptable. Here's a 3D multiplanar display. Again, you can use certainly 3D for cervical ultrasound, but it's really not been shown to be very helpful, except for getting nice pictures here for lectures. As you can see here, these pictures are over 10 years old, and they're beautiful pictures of the cervix in the 3 different planes. Here is an ultrasound showing significant funneling and even some sludge, significant amount of sludge at the bottom of the cervix. This woman has a cervix that it's only now 1 or 2 millimeters, and the presence of sludge means inflammation. Her risk of delivering preterm, it's over 90% at this point. Here's a picture of a woman with a cerclage. This is the usual sagittal view in the upper right with the 2 spots of the cerclage. You can see here that on the different 3D view, the axial view, you can see the whole suture. Here is another nice 3D that depicts the fact that on the coronal view, you can really tell what the true endocervical canal axis is and get the most accurate cervical length view. Again, this difference from regular 2D ultrasound, it's only 1 to 2 millimeters most of the time, and so it's probably not clinically important, but certainly may be important in the future for future research efforts. Using an image of the whole cerclage around the endocervical canal. We'll talk a lot about cerclage in the next few slides. These are live 3D, 4D view again of the cervix. The lady that had funneling, we place a cerclage high in their uterus, and as you can see, it's keeping the cervix closed, at least the lower 2 centimeters, and it's straight around the endocervical canal and keeping it closed, even if, as you can see here, membranes are trying to bulge down, and you can see some sludge as well. Here's a picture of a cerclage that has not worked. A lot of the times clinicians don't anchor it too well to the posterior part of the cervix, and the cerclage can slip. And obviously in this situation, as it is only in the anterior lip of the cervix, it won't be very efficacious for predicting and preventing preterm birth. So normal cervical length, when you should measure it, which is between 14 and 28 to 30 weeks, is about 25 to 50 millimeters. As I showed you, it is not helpful before 14 weeks. And if it is less than 25 millimeters or less than an inch between 14 and 24 weeks, that is abnormal. And as you can see in this classic graph by Dr. Iams, the shorter the cervical length is, the higher is the incidence of preterm birth. Again, the number that you get from the cervical length is very predictive of when the woman is going to deliver. It's also important, though, not to just look at the number, the cervical length number in millimeters. It's also important to look at many other factors, one of which is when you get it. If you get, for example, cervical length measurements of 10 millimeters at 16 weeks, the risk may be up to almost 60% for delivering preterm, 50 to 60%. While if you get the same measurements at week 28, when it's almost physiologic to begin to shorten, but since the shortening is significant, the lady still has a risk, but the risk is less than 40% of delivering preterm. So very important to put it in perspective with gestational age. When should you do it? If you do just one screening for preterm birth in low-risk patients, I will recommend to do it around 18 to 22 weeks, because that's the mean time in which the cervix shortens in women destined to deliver preterm. Obviously, if you do it more often, the prediction is higher, but possibly that more frequent screening should really be only in populations at high risk of preterm birth, such as those with prior preterm birth, in which often we do screening every 2 weeks, between 16 and 24 weeks. And it's also important to look at outcomes. Outcomes are related to the populations you studied, and all of these populations have been studied now in multiple studies in terms of prediction of preterm birth with transvaginal cervical length, and all of the studies have reported that transvaginal cervical length is predictive of preterm birth in all of the populations. Singleton are high or low risk for preterm birth with different high risk factors, multiple gestation, twins and triplets, and also symptomatic women with preterm labor or PPROM. This is a classic slide from the best blinded studies of transvaginal ultrasound. So these women did not have intervention, and you can follow the natural history of screening with transvaginal cervical length. They all used a cutoff of 25 millimeters, which is pretty much the one most used in clinical practice now. They screened in the second trimester between 16 and 24 weeks, and they looked at preterm birth at less than 35 weeks. As you can see, the sensitivity is actually quite low in low-risk women and highest in high-risk women with a prior preterm birth. And also the positive predictive value is much higher in these high-risk women with a previous preterm birth. So really, as a test, transvaginal ultrasound won't do too well in low-risk women with a low background a priori incidence of preterm birth. Will do best in singleton with a prior preterm birth or some kind of other high-risk factors, and won't do that well either in twins because, again, while the positive predictive value is high because of a high incidence of preterm birth, the sensitivity is very low, probably because twins have opening of the cervix only after stretching and maybe even some asymptomatic contractions of the uterus, and they're not really a risk for cervical insufficiency. Their cervix is fine, and that's why looking at it won't help too much in predicting preterm birth.